We are delighted to welcome Dr. Melanie Sisti today, who is a psychiatrist at the Weill Cornell Medical Center, and she's going to talk to us about mental health and depression.
My name is Dr. Melanie Sisti. I am a consultation liaison psychiatrist at the Center for Special Studies at New York Presbyterian Hospital. Just to begin, one question that comes up a lot for me in my life when I tell people I'm a psychiatrist is, oh, is that a person who does therapy? Is that a person who prescribes medicines? Like, how do you sort it all out? And it is really confusing. I'm a medical doctor. I went to medical school and then did a residency and then actually continued after my residency training in the care of people who have both a psychiatric diagnosis or condition that they're working on and also a medical condition. And I really liked that complexity of a person who's really dealing with their mind and their body at the same time. Although in reality, who isn't? We are all dealing with our minds and our bodies. There are some diagnoses in medicine that we do find people do their best when they have the psychiatric support as well, and HIV is one of them. So for the past 11 years, I've been working exclusively with people who are living with HIV and AIDS, or people who are more recently, I've also included people who are at risk of getting HIV and AIDS in that population as we're spending more time and effort in prevention of transmission. I figured I'd, just talk a little bit about what depression even is when we use that term, and then some of the risk factors. We can talk about medication, therapy, and some behaviors. Those three would be sort of ways of approaching mental health and depression. So I thought I'd start with a case just so that we can think about like how this might be something we encounter in our own lives. So your cousin Lucy was laid off of her job several months ago. Finances are tight. Initially, she was calling you to vent. Her kids and her partner are frustrated with new budget constraints. They're stressing her out. You usually see her at church or run into her walking her dog, but it's been several weeks since that's happened. She's kind of just gone off the radar. You've texted several times, but you don't get much more than like one-word answers in response. So, I think that this is sort of the kind of scenario that we do encounter in our lives, in our family, and with friends that it's a stressful time, and then you're wondering, is this depression? Like, what are we even talking about when we say depression? Because certainly, we all feel sad sometimes. It's a normal human emotion, and we can't get rid of it. We shouldn't. Like, we need our emotions. So at what point do we call it like depression? And at what point does a psychiatrist get involved? And those are the things that can get really a little bit more complicated. So what is depression? So being sad is a normal reaction. Usually the sadness will go away. Depression is different. It's a mood disorder that can cause more severe symptoms. I like to think of it as sort of like it's not just a mood. It's about how you're functioning, how you're thinking, how you're handling the things that you need to handle in your daily life. Just your overall sort of constellation of how you're moving through the world is affected. So whereas, we have troubling news reports that we hear every morning, right, when we wake up, and we'll feel sad about that. But then we continue with our day. Being depressed would be different from that. That's an emotion that you're not really shaking off or move through your day after experiencing. There's the emotion, and then there's the diagnosis of depression. As a psychiatrist, we have different kinds of depression, even when it does reach that sort of clinical threshold. And the one I'll talk about the most today is major depressive disorder, which is sort of going to include that constellation of symptoms. But you also can see depression, bipolar depression. There are some people who have a chronic sort of low-level depression that we call dysthymia. So, there are a lot of sort of bells and whistles and different sort of labels that we might use. But for today, we'll just sort of think about major depression. So when we're diagnosing that, we're looking to meet the criteria. So the first thing that you'll always see is like 2 weeks of pretty persistent depressed mood or anhedonia. And anhedonia is sort of a term that means that you're not really taking pleasure in things. So people will take their kids to the park, but they'll kind of look at them and just sort of be like, well, that used to be something I really derive joy from, but I'm not now. Or, they'll go to church, but the songs, don't uplift them the way they did. So it's that like lack of pleasure from things that used to be pleasurable activities. So one or the other needs to be sort of present when I'm seeing a patient to really think this is a major depressive episode. It needs to last about 2 weeks. They can both be present too. And then it's just sort of like, what other things are we going to add to that clinical picture? Like, so I'll ask somebody who comes into my office to talk about depression, somebody like Lucy, for example, like what kind of thoughts are they having about themselves? Like, how do they feel about themselves and the person they are? And a lot of times you'll hear like just feeling like, they're pointless. They feel guilty. They feel like they don't do things right. They're kind of ruminating on that and thinking about it a lot and not feeling that sense of value in themselves. Sleep changes are a hallmark of depression. That can be increased sleep or decreased sleep. So some people will say, they're not sleeping well at all. They're exhausted. Other people say they're sleeping 14 hours and they still feel tired the next day. Same with appetite change. Our appetites can fluctuate from day to day, but when people are experiencing a major depressive episode, at least in the beginning, if it's persistent, then your weight can only change so much. But usually in the first few weeks or month of a depressive episode, we will see that somebody's either comforting themselves with food and really eating a lot more, or they really have stopped eating and aren't getting the nourishment that they need. Psychomotor changes. I put a picture of a turtle here. Again, that's another one that, like sleep changes and appetite changes, can go either way. Some people are really agitated. They feel really restless and annoyed. And then other people will sort of be moving like a turtle, just really sloth-like and having a hard time activating any sort of behavior. It just all seems like too much work. Low energy is typical for people who are experiencing depression. Poor concentration. I think we've all probably experienced the time when you pick up a book and you're trying to read and you're on the same page for a long time. That can happen for a number of reasons. But, with depression, again, we're seeing, that it's just happening over and over. Like I'll often have people who come in and just say, they can't get through the things that they used to be able to get through at work. They just can't stay on task. They're drifting off. They're going back to these sort of negative thoughts and feelings about themselves. And then finally, the one that we, really worry about is suicidal ideation. So when a person is feeling all of these other symptoms, they can also sometimes then begin to have suicidal thoughts. Or for somebody who has chronic thoughts of death, those thoughts can intensify. So those are sort of the symptoms. And you can see how, two people who have a diagnosis of major depression could actually look really different. Like one might have a really depressed, irritable mood, but is not sleeping, is not eating, is really agitated, is feeling really, just antsy and irritable and almost like activated. Whereas another person with depression could really be slowing down and just feeling really sluggish. So, two people with depression can really present differently. There are also some other symptoms when depression, there are different levels of severity of depression. So some people will have a mild depression. Some people, the symptoms will be more intense. And then we can even see severe depressions where people begin to have a change in the way they're thinking that's really a break from reality, even where they begin to have just what we call like mood congruent psychotic thoughts. So, just thinking almost in a paranoid way or a really sort of just non-reality based way, it can really start to distort the way they're thinking. So if Lucy is your cousin and you're starting to notice these things, like what are some of the things you would want to do? I think that the first thing that's always on my mind, and I think, as a clinician and also just, as a person, would be just making sure that that person is safe. So safety is always just an important thing to establish. There are actually studies looking at, like, is it okay to ask somebody who's feeling depressed if they're thinking about suicide, or will that plant the idea in their head? And what we know is it doesn't. It's important to talk about it. It's important to flesh out and understand some of those thoughts they may be feeling. It is not going to give them the idea if they weren't having it. So some of the things that I would ask somebody would be like, are you thinking you don't want to go on? Are you wishing that you could go to bed and not wake up? Are you actually starting to think about ways that you would make that happen? You're not, that you're having more active thoughts, planning. Have you been giving things away? Have you been sort of checking out your life insurance policy? Have you been sort of having your parting words or last sort of meals with people? Do you really have that intent? Like, are the thoughts there, but then you push them back? Or are the thoughts there and you're really thinking, yeah, this is, I'm going to do it. And then finally, like, what kind of access to potentially deadly means does a person have? So one of the things that people will sometimes think is, well, if there's a will, there's a way. If somebody really wants to end their life, they will. But what we know is actually a lot of times a suicide attempt, or unfortunately a completed suicide, can be pretty impulsive behavior. Even for somebody who's depressed and who's been thinking about it in that moment, there are many sort of incidences where somebody will just have a suicidal impulse. And if they have quick and easy access to a way to end their lives, that's so much more dangerous. So there have been public health efforts actually to diminish the access. And that's why you'll see phones on bridges, suicide emergency phones. They've even put down netting or raised fences on like the San Francisco Bridge, for example. So just ways to really help people who are really in that sort of final stage and sort of going into a really dangerous zone, get there with that plan in their head and then see an obstacle, and then actually they'll turn around and leave, or they'll make the phone call and get. So it does make a difference. And I think that's helpful to know. And then finally, of course, access to guns is just such a violent and final and immediate way of ending things. So again, if somebody is, a gun owner, it's important to have that conversation with them. In New York, we don't have as much of a gun culture as I think that we see in other parts of the country, but it's still something to think about, particularly with people who've been in the armed forces, if they've been in the military, if they've been in the police force, then just to think about whether, they have that access to a gun or have a gun in their house. And it might be a good time to talk about, just where to keep it, just to help them feel safe during a time that's difficult. I think that people probably know this, but 911 was recently changed to 988, and it also has texting abilities. So New York City has done a fair amount of public health efforts for helping with people who are in mental health crises. And I think that having those chat functions on emergency lines has been helpful. And I've even had a number of my own patients who are obviously already in care tell me that they've had moments when they just really needed that access and have used it. So that's something also to know about. So when we're thinking about somebody, if they're at risk for suicide, there are things that can be really protective and things that can put them at higher risk. And some of them are modifiable things, some of them aren't. People who are in good health, people who are connected to their religion and have a religious community, having a job or some sort of work or daily demand, really, like an expectation that they'll be somewhere and there's something that they need to take care of, pet ownership, resources. That includes, financial resources, unfortunately, not so easy to fix always, but these tend to be protective. That doesn't mean it doesn't happen. Of course it does, but these are things that can sort of help reduce the risk of completed suicide. And then on the opposite end, we have things that can really increase somebody's risk, and that would be things like access to a deadly method. For me, I've talked to patients who do have either chronic suicidal thoughts or increased suicidal thoughts about removing things in their home that might be problematic to have in, one of those vulnerable moments, including large canisters of Tylenol, which can be deadly in overdose. Of course, guns, but just sort of getting those things out of their access during that time when they're feeling more vulnerable. Social isolation. I think we all became more aware of just how challenging the impact of isolation can be over these past few years with COVID. I think that there's that initial sort of several week period where everybody had to stay at home and we thought we'd lose our minds, and we only partially grew accustomed to it, and it just became this long protracted period of time when a lot of social activities were shut down, a lot of the community that people were engaged in ended, and just really, I think, is a mental health crisis that we're still dealing with and not out of. Drug use can increase the risk of suicide. That includes drugs and alcohol. That's twofold. One would be because in the moment of intoxication, it increases impulsivity, but it also can just sort of perpetuate depressive symptoms. So that's another thing that we try to look at when we're worried about somebody really not being stable or being at higher risk is sort of, what can be modified? That's one. Living with chronic pain is a risk for suicide. Then also family and personal history of suicide attempts and completed suicides. For somebody who has a parent who died by suicide or a grandparent, a sibling, that's someone I would take really seriously. There's a heritability to suicide itself that's important to take into consideration as well. But I also wanted to just sort of touch base on a couple of the other depressive sort of disorders that can come up in a woman's life. One is premenstrual dysphoric disorder. For a long time, this wasn't really, I think, fully appreciated and recognized. There's premenstrual syndrome where, people can notice that before their period, they feel a little bit more irritable, a little tired, achy, that's normal. That just is a response to the normal hormonal fluctuations. But there is a subset of people who have premenstrual dysphoric disorder who really have true depressive symptoms that are quite severe and really impacts their ability to function during those 2 weeks before their period. So that is something that's worth recognizing. I will ask my patients who menstruate about that and about whether they've noticed that kind of a pattern to it, because how we approach that might be different from how we would approach other depressions. There's also perinatal depression. People say, I think in the media, we hear a lot about postpartum depression, but we actually need to expand how we think about that. That depression can begin during the pregnancy. It's a more severe and persistent thing than the baby blues. There's that sort of period of time right after birth when a woman can have some low mood and anxiety, and that resolves after a couple of weeks. This would be more pervasive. This really would sort of meet that criteria that we looked at before for major depression. It's hormone mediated. And again, just like premenstrual dysphoric disorder, it's important to know and think about, because when we're thinking about the cause, when we're thinking about what's causing it, it can help us understand how to help treat it as well. And we even have a new medication available now in the world of psychiatry to treat that very effectively. And then the final one would be perimenopausal depression, which can last for several years. And during that period of time when the hormones are shifting, it includes sleep irregularities, mood shifts, hot flashes, waking, muscle loss, all of these things that happen during that perimenopause stage. But for some people, they really can experience like a lifetime first depressive episode during that period of time. There are some people that are more sensitive to hormone shifts than others. So I do think, sometimes when I see somebody who's pregnant, it can be helpful to ask them, like, what's been their experience with hormone changes with their menstrual cycle already, or what's been their own mother's experience going through menopause. Like we do see that there's some heritability there with that, and also just some true biological sensitivity in some people. So in terms of, we kind of just started getting into that, what causes depression, like what would be some risk factors? There is that genetic component, the heritability of it. There's the nutritional component. And I was excited when I was looking at the Smart University program to see that you all have been ahead of the sort of curve with that in terms of recognizing the importance of proper nutrition for overall health, physical health, and also mental health. If we don't have the right ingredients, then it's just impossible to have the brain function at its sort of optimal level. So there are a lot of sort of recognized nutritional deficiencies, but then there are also subsyndromal sort of deficiencies that can affect how we're feeling on a day-to-day basis. If anybody just thinks about how they feel after like a sugar rush and then a crash. It sort of gives you a little bit of a view of how food and nutrition can really affect our emotions. This also kind of speaks to a bit of the social determinants of health between nutrition, stress, and poverty. We just know that it is hard to chip away at a depressive episode if somebody doesn't have access to proper food, if they're living in a food desert where the stores are just not going to provide them with things like fresh fruits and vegetables, trying to eat closer to the earth. Stress and poverty also with housing. We certainly know in New York City, it's so difficult to find good housing. And, a lot of people are exposed to heat, cold, noise, and safety issues in the housing that they live in. And that's certainly going to affect somebody's sense of well-being and their mental health. Medical causes, I won't go into them all, but there are a number of medical conditions that can cause depression. Thyroid function can do that, anemia. People who have experienced trauma and loss, both in the immediate sort of picture and then also childhood trauma and loss, can really increase the risk of lifetime depressive episodes. There are certain personality traits that also are at higher risk of depression. And some of those traits might be sort of a sense that the control is outside of them, that they don't have autonomy or agency in their own lives, that it's all done for them, that lack of ownership of control can really put people at more risk for having depression, feeling really hopeless and helpless. Medications specific to HIV, there are a number of medications that we know can affect mental health, that can cause depression or even psychosis. Fortunately, we've seen such an evolution of the medications that are available that we're able to avoid some of them, and at least in the US. So we see less use of things like efavirenz, which we know can cause depression and actually has a twofold increase of suicide attempts, completed suicides. Some of the newer medications are better tolerated. For some people, they're not. For some people, they struggle with the integrase strand inhibitors. So it's always something that we try to keep an eye on here if somebody's changing their medications, just to make sure that they're still getting sleep, that they haven't had any changes in their thoughts, their feelings, or behavior. And there's certainly many medications outside of the sort of HIV world as well that can affect mood and predispose somebody to a depression. And then, of course, drug use. Some drugs specifically are higher risk than others. Alcohol use, crystal meth, cocaine, those are all sort of higher risk for creating depression. So those are some of the things that can be causes or risk factors for a depressive episode or for persistent low mood as well. So then what do we do when, somebody like Lucy comes into the office here? Like what would I have to offer her? Of course, there's the option of taking medications for depression. Not everybody wants to take medications. I do strongly encourage or think about medications as something to recommend for somebody who's having a more severe or persistent depression. People who have multiple episodes of depression in their lives tend to find that they really do better if they're on medication, both for treatment of depressive episodes and for maintenance of inter-episode sort of functioning to sort of reduce the number of recurrences. There's therapy, and then there's also self-help, and those are things that people can do. The talk is actually mental health and depression. So I like to think that they're things that are really helpful for people who are having a depressive episode, but they're also based in just the reality that we are all people living with minds and moods and bodies, and that they help us all sort of function at our best. So in terms of the medications, there are pros and cons. Some of the pros would be that they are generally effective and well tolerated for most people. They can also simultaneously improve other conditions. They can also enhance people's response to other interventions. So somebody might come in to me with a depressive episode and say, they really only want to do therapy, or they want to try just exercising first. But what we do know is that combining those things can give a better response rate, and they can shorten the period of time to improving. So, sometimes somebody will come back to me, or their therapist will reach out and say, we've spent 6 months now working on, behavioral interventions and talking about things in therapy, and it's going nowhere. The depression is just too severe. But the cons are that it's not easily accessible for everybody to get on medication. We know even in New York, where there are so many psychiatrists, it's, good luck finding one that's affordable and who takes your insurance, or, who's taking new patients right now. So that can be a challenge. And medications aren't immediately effective. They take about 4 to 6 weeks. Sometimes sometimes the first medication a patient tries isn't going to be the one that they respond to. So they need to then buy more time just adjusting that. And then they can have adverse effects. So they are generally effective and well tolerated. They're generally safe, but no medication is going to come without any side effects at all. That's just the price to pay to some extent. So there are some commonly used antidepressants that, I think most people are familiar with a few of them. The SSRIs include things like Prozac, Zoloft, Lexapro, Celexa. They're really well tolerated. The reason they're so common now is really because of that. They're effective and generally well tolerated. They do, though, cause sexual side effects for most people that take them. For some people, that can be a real deal breaker, particularly, men who have concerns about their ability to get or maintain an erection, but it can be a concern across the board for people. SSRIs are actually first-line treatment for anxiety disorders, which I haven't talked about today, but it's an elegant way to sort of kill two birds with one stone, because we do know that depression and anxiety travel together often. Similar to SSRIs or SNRIs, which are kind of just almost like a boosted version. They kind of just work on two transmitters. So one is serotonin and the other is norepinephrine. The nice thing about that is that they can also be a little bit helpful for pain. So people who have chronic pain disorders or neuropathic pain related to HIV can do well with medications of that kind. There's bupropion, which is also known as, well, you'll see a lot of just minuses. It doesn't do this, it doesn't do that here. But actually, this is a really effective and popular medication because it isn't sedating, it doesn't cause weight gain, doesn't have sexual side effects. But unfortunately, it also doesn't tend to do very much for anxiety. And for some people, it can actually make it worse. But it can have its purposes. It can be really helpful for people actually who are working on smoking cessation as well. It's marketed under the name Zyban for that, but it's the same medication. For some people who, just going back to the early symptoms about depression and that sort of anxious, irritable, not sleeping, not eating kind of depression, mirtazapine is a really special medication that can be helpful. It's very sedating. It also does cause a lot of weight gain. So when I see somebody who's either really struggled to take their HIV medications, they might have some wasting, they're not eating, they're not sleeping, or sometimes when somebody's actively getting cancer treatment, this is a really fantastic medication to give for that. But again, it does cause weight gain and sedation. And then there are the tricyclic antidepressants like nortriptyline and amitriptyline. They used to be the first-line treatment for depression a couple decades ago. They've fallen out of favor because they are a little bit harder to take, but they are still used for some people because they can be particularly helpful for pain conditions, and they can help. The sedation is, depending on who you're talking to, is either a side effect or just a benefit. And for some people, sedation from an antidepressant can be really helpful. So that's sort of a quick sort of run through the medications that we typically use. In terms of psychotherapy, I think, the first thing to acknowledge is just that there are access issues when it comes to psychotherapy. It can be very difficult to who's taking new patients right now. So I just want to sort of put that disclaimer out there. During psychotherapy, you kind of learn about the condition, the moods, feelings, thoughts, and behavior, and it helps sort of take control and respond to challenging situations in a healthy way. And there are a lot of different kinds of therapy out there, and it can be helpful to sort of think about what's going to make the most sense for a condition that somebody is experiencing. So there's cognitive behavioral therapy, which can sort of look at some of those negative thoughts that people with depression can experience, those feelings of worthlessness, the rumination, and start to challenge those thoughts and have a response to them. almost like talking to yourself about that. Like, no, that's not true. The evidence doesn't support that. I'm more behavioral techniques to cope with depressive symptoms also can be helpful. Sleep hygiene can come in that way. Just trying to make efforts to regulate the sleep cycle. Dialectical behavioral therapy is sort of an offshoot of cognitive behavioral therapy that can also be really helpful for depression and for coping, for developing healthy coping skills. Psychodynamic psychotherapy I mentioned here, it's really not the thing that would be the most appropriate for somebody who's having an acute depressive episode, maybe for somebody who's chronically dysthymic. I mention it just because I want to make sure to sort of acknowledge its existence. This is kind of like the original therapy. It's the kind that you think of when you're thinking of like Freud and the couch or the sofa that people like lie down on and talk. But this tends to be a little less action oriented and a little less immediate for somebody who's really having those symptoms. Acceptance and commitment therapy is kind of what it sounds like. And then supportive psychotherapy is just working really directly on identifying coping skills and finding the ones that are going to be the most appropriate and helpful in a situation. We all have different ways that we typically cope with things, and it can be important to think about really naming those coping skills and making sure that we're using them effectively and not overly relying on one coping skill at the cost of others, because sometimes life throws things at us and we really need to have a whole toolbox of ways to cope, and one alone isn't going to do the trick. Finally, there's self-help and behavioral activation, which I think is so important to think about. Going back to like Lucy, the friend who you're not seeing anymore. Some of these things I've talked about, like the medications and therapy, might not be something that you can really give or connect your friend or your cousin with. But what can you do that can help them with their depressive symptoms? These are some evidence-based things. So we have good studies looking at this. So spending time in nature, it sounds kind of like woo out there, but we are human, we're animals. And I think that sometimes when we're in the city, we lose sight of that, but it can be really helpful to be grounded on the earth, breathing the air and just taking in nature. It can help to regulate sleep. We're supposed to be awake during the day and asleep at night. And as we're living with artificial light, we're seeing all of these disruptions with our sleep-wake cycle, and our bodies and our minds react to that. People who work night shifts have shorter lifespans. They have more chronic health conditions. It's just not how humans were developed over centuries and millennium to function. We really need to sometimes just think about how removed from our nature we've become, our biological nature. Relaxation techniques and breathing exercises. There are a number of different ways to relax the body and the mind, which are again connected. Progressive muscle relaxation can be helpful. Breathing exercises. People think, well, I breathe all the time, but really sort of harnessing that breath and using it, counting in, holding it, can really reset some of our most primal sort of organ systems and functioning. So when I'm feeling anxious, I'll do that. Before talking today, actually, to collect my thoughts. So I have a talk. There's a million things I could say. How am I going to get it all in? I stopped and just took 3 long, slow breaths, and it helped me get back to just sort of thinking about how I'm going to move through this and pace myself. So it's a nice reset. I like to think of it as like rebooting a computer when things start getting sticky or not running right. Exercise. It's important to separate thoughts about exercise from diet culture. We have bodies that need to move. They don't have to look like somebody else's body moving. It's just important to reduce sedentary behaviors. So moving around, waving your arms, waving your legs, just making sure that you're kind of keeping those joints lubricated and moving is so important. Yoga, cardiac exercise, weight training all have studies supporting their use for depression. But at the least, if somebody like your cousin Lucy is not walking her dog anymore, she's only going to start feeling worse if she's not leaving. Her body will become stiff. She will become lethargic. She won't feel well. So getting that movement back in is so important. Nutrition, avoiding processed foods, eating closer to the earth. I think I don't have to say much about that because I know it's already part of the SMART university, awareness and curriculum, having a sense of purpose. That's so important, to have something that you're waking up to do every day. The worst thing that could happen is, to win the lottery and decide to take to your bed and just relax forever, maybe a couple days. But after a while, watching Netflix in bed, will start to come at costs. So yeah, having that sense of purpose, having that community, getting up, working, volunteering, connecting to other people. We're human. Humans are social. Quitting smoking, drugs, and alcohol, of course. So if you had a person in your life that you were concerned about, then talking about ways to make some changes and focus on health would include that. And then stress management, mindfulness exercises can be very helpful. I mentioned them before when talking about therapy, but they're also things that can and are certainly done just in regular day-to-day life. And very importantly, screen detox. We have studies now looking at the effect of social media and then just screen exposure in general, and it's detrimental to the health. In some ways, it can be so cool. Like right now, I'm able to connect with everybody and talk, and it can build that community. But if you're finding that your screen time report is that you're spending 3 hours on Instagram looking at influencers, then maybe that's not helping so much. Maybe there's a way to modify screen use. Certainly, screens in bed are an issue for insomnia, and we know that insomnia and that sleep dysregulation happens with depression. So keeping screens out of the bedroom as much as possible, or at least not turning them on during times when the brain is supposed to be not getting light exposure and is supposed to be recognizing that it's time to wind down and sleep, is really important.
Is there one that's sort of like a first line sort of therapy that you would look at for a major depressive disorder? Like, what are the kinds of things that you'd be looking out for if you're looking for a therapist for depression specifically?
So a number of them are evidence-based for treating depression. Sometimes it's just a matter of what kind of therapy you think is going to make sense for you. For me, I like the idea of having assignments. I think I spent a lot of time in my life as a student and learning. So cognitive behavioral therapy is a kind that really has that. There's going to be an expectation that there's worksheets, you go home with it, you're going to be making some changes that can be great for that behavioral activation. But then other people say, that's not when they're feeling down what they want. They really want somebody who can sort of listen, maybe gently come up with a few ideas together. Adding homework would be the last thing that they want because they already feel like they've got more than they can manage. So I think it's just something to sort of be aware of, that maybe different personalities might find that they're more drawn to one kind of therapy versus another.
And you can ask a therapist what's their mode of therapy. That's a totally legitimate thing to ask someone, right?
Absolutely. It should be collaborative, and it should be sort of a process that's come together. Ideally, a therapist has different modalities at their disposal and can really think about what is appropriate and tailor-made for the person in front of them.
So if somebody's been through trauma, is there a particular sort of modality of therapy that would be, or is it again, sort of up to the person and the therapist working together?
Yeah, there are trauma-based therapies that can be really helpful, that are evidence-based, also well-studied. I think that the sort of old thought was that, therapy is just talking about things, and talking about things works and it makes you feel better. And that's absolutely not true. And anybody who's living with a history of trauma and is still symptomatic would be the first person to tell you that actually revisiting a traumatic event in a sort of unscripted, unplanned, willy-nilly way can actually be really harmful. It's really not how we recommend talking about those things. So it is important to sort of recognize that, just putting it all out there, just talking about it is not therapy. That's, that we really reserve talking about trauma for these meaningful sort of specific types of therapy.
What do you think about these online therapy apps what is your sort of BetterHelp is one that was mentioned.
Mhm.
Does that help with access? What's your kind of opinion on that?
I think it's a great way to improve access. Absolutely. And I think it can be empowering for people who are symptomatic and don't have other ways to access therapy. And I personally, during the COVID pandemic, one silver lining has been that I'm able, for the first time after working with people for nearly a decade, to actually see them in their environment, to see, their pets, to see how they're maintaining their home. Some people have spotless homes. Other people are really struggling just to keep up with keeping it clean or really safe for themselves. So I think online therapy is a great, great option. What I do have concerns about is that some online therapy, I think, is really geared towards sort of working backwards from a diagnosis almost. Like I've seen ads that say, do you have trouble concentrating? Do you have blah? And then you may have ADHD. Do this and come on, I think that, it worries me when I hear that it's almost like a pill mill or just a sort of way to get more prescriptions out there without a nuanced sort of understanding of what's happening with somebody. And, we know that medications alone really aren't going to solve all of life's issues and can actually create problems. So I think the important thing is, like, if we're looking at therapy, then it's really somebody who's going to be spending the time actually providing therapy.
In that situation where you are dealing with somebody else who might be depressed or trying to support somebody else who might be depressed, at what point would you say that you ask for outside intervention? I know that there's a lot of that is clearly up to the person accessing services, but at what point do you say, I'm really worried about this person and I can't support them in the way that I think they need? So what would you do in that situation, or how do you know that it's time to do that?
It's really hard to help somebody who may not want or be motivated for the help, but I think that the metric to sort of use is the safety issue. So if they're really unsafe, if you're really concerned that there's an imminent risk that somebody in the home or the person who's experiencing depression really not going to be able to keep themselves safe, then that's a reason to be more assertive about the support. And that can even include calling 911. Sometimes that can include just calling a person's doctor. The doctor can't speak to you, but they can be informed of an area of concern. If there are children in the home, children are not able to care for themselves. Of course, they need to have a parent who's able to provide for them. So even, if you don't think that a parent, for example, is at risk of ending their own life imminently, then if they're not able to provide basic care for their children, then that's a reason to escalate the intervention.
And in that case, would you call 988? Is 988 where you would go with that, or 911? Like, how do you know which one is the right one to call?
You don't need to know the right one. If you call, then you'll get directed.
Cool.
Yeah.
Okay.
Once you call, they can start bringing you in the right direction, whether it's an appropriate ACS referral, they can be anonymous, or whether it's about bringing, a mobile crisis or an emergency service to the home to evaluate the person. The nice thing is that they're kind of trained to triage. So in that moment of sort of anxiety or panic about what to do about somebody, you don't need to have all the resources at your fingertips to figure it out.
Got it.